Thanks very much. And thanks for the help with the AV. Obviously, that's one of those issues that goes cross-country, much like compartment syndrome. Um, anyway, thanks very much, Steve and Zane, for the invitation to come and get a chance to talk to you guys. I do appreciate it. So I'm going to be talking about compartment syndrome of the legs and of the extremities predominantly. I will acknowledge all the people that have helped me with all the various sort of research projects that we've done on compartment syndrome. Certainly not all my work, and take advantage of the support you have. And of course, to mention that we do have both peer-reviewed and industry support for the projects that are going to be discussed. So I'm going to talk a bit about the biology, a bit about diagnostic issues, and then some concepts related to current and forthcoming treatments for compartment syndrome. I think most of us, or all of us, are really aware of the severity of compartment syndrome. It is, of course, a limb-threatening condition, leading cause of amputation and trauma, and certainly the #1 cause of litigation and fracture care, which is something that, obviously the patient outcome is important and the leading thing that drives us forward, but everybody always worries quite a lot about litigation in terms of their medical practice as well. Compartment syndrome is still the #1 cause of litigation, and thanks to the efforts that have been done, it has now supplanted wrong-sided surgery by a factor of about 3 to 1 in terms of the incidence of litigation in Canada. So what is compartment syndrome? It's elevated tissue pressure in a closed fascial space that ultimately reduces tissue perfusion, leading to the death of the muscle and the nerve cells. It's got to be a tight compartment. It's got to be a closed, intact fascial space. And it's always been thought of as predominantly a perfusion issue, meaning that the issue of the pressure leading to the decrease in perfusion is the primary pathologic problem. Normal perfusion of the muscle is a good balance of arterial inflow and venous outflow, and with nice, healthy skin around the muscle, everything looks relatively healthy, pink, and really intact. And that's normal muscle perfusion. But in compartment syndrome, things get changed. You can have an inflow problem leading to issues. You can have an outflow problem. And ultimately, the bottom line is you get muscle cell death as a result of the pressure that's pushing on the muscle. And it's more of this kind of situation where the swelling just builds up and up and up unless it's released at some point in the course of the evening. So this is our typical clinical presentation, or fortunately an atypical clinical presentation. It's how it's originally described, which is ischemia and venous stasis in the forearm leading to contracture. Volkmann described it as a purely arterial problem with diminished inflow, and thankfully we see very few cases that end up like in this slide at this point in time. In terms of the etiology, again, it's an inflow problem or an outflow problem. And and the inflow side, the most common is fractures, which is where I'm involved for the most part, but also blunt trauma and ischemia or reperfusion injuries are well up there. We do still get line injuries resulting in compartment syndrome for sure. In southern Ontario, there's very few snake bites resulting in compartment syndrome, thankfully. On the outflow side, obviously a tight cast can contribute to it, as can an overaggressive fascial closure or burns. Steve had has had the experience of dealing with prolonged direct pressure outflow issues and compartment syndrome, and I think your case was a gluteal compartment syndrome, right, Steve? So another cause of tight butt is a compartment syndrome. In terms of the diagnosis, we're all familiar with or taught the multiple P's involved in the diagnosis of compartment syndrome. We can go through them. It's basically pain out of proportion, resulting in a tense or palpably tense compartment that ultimately ends up with pain on passive stretch of the muscles involved in the compartment. And that's where we're all sort of comfortable with the diagnosis. And as things progress, you get paresthesia and unfortunately ultimately leading to paralysis and pulselessness. Basically, as a bottom line is if you catch it in the yellow zone, you're probably going to avoid the worst of the problems. In terms of the etiology of this, we know that there's some combination of time and pressure that ultimately results in cellular injury and cell death. Again, it is the most frequent cause of litigation in orthopedic trauma, usually because of a misdiagnosis or an incomplete diagnosis, but occasionally because of incomplete fasciotomies haven't been performed. So what about the diagnosis? Since diagnosis is such a critical issue in terms of protecting our patients and ourselves from problems? How good are we at actually doing the diagnosis? And it depends on your source, really, because pain as a diagnostic tool can often be very difficult to assess. We have patients with different pain thresholds, some of whom we have a very difficult time telling whether their pain is truly out of proportion or whether it's more intrinsic. Similarly, pain with passive stretch is described as possibly the most reliable sign, but alternatively is described as both subjective and unreliable. And when you think about it, really, we're trying to define a threshold for diagnosis based on pain. And really, it's never been successful for anything in medicine to define pain as a threshold for diagnosis. So what is this threshold between normal and compartment syndrome? And the problem is it's not a dichotomous issue. If you took 100 patients with tibial fractures and asked them to quantify their pain from 0 to 10, you'd have a gradient something like this. And which of those patients have compartment syndrome? Do you define it at 9 out of 10, or maybe 7 out of 10? Or really, obviously, we're going to have a more difficult time than that, defining how much pain really correlates with compartment syndrome. So in terms of the reliability of clinical exam, it's unfortunately not as good as we'd like. Todd Ulmer did a meta-analysis of various papers showing that our sensitivity to detect compartment syndrome is really quite poor, at 13 to 19%, with a low positive predictive value as well. In terms of specificity, it's quite high, so we're probably good at ruling out compartment syndrome when we have a complete absence of any clinical findings, but ruling it in as a definite diagnosis is more difficult. And that's a problem because this is a situation where we have a diagnosis with very severe adverse clinical sequelae. And this is a case where we want to probably overcall as opposed to undercall. In children, it's even more difficult. Looking at cases in kids, all of the P's are basically, unfortunately, unreliable. And really, the only most sensitive test for detecting compartment syndrome in children is the increasing requirement for analgesia. And furthermore, we know that delayed diagnosis is a problem, and this has been shown by a number of papers going back to as far as the 70s, looking at the incidence of severe muscle-related complications. These are things like horrendous contractures, amputations, problems that definitely were debilitating for the individuals involved. The risk of complications for a late fasciotomy compared to an early fasciotomy is, what, 10 times, 15 times? So very substantial. With early fasciotomy, we get those complications down to at least a manageable threshold, but with a late fasciotomy, it is an issue. So that brings up the issue of compartment pressure measurements, which are known to be a clinical adjunct for a suspected compartment syndrome, especially in the case of an equivocal or an unreliable exam. So a narcotized patient or somebody in the ICU, a patient with a head injury, pressure measurements are a very useful clinical adjunct. In terms of interpreting them, again, we're running into a problem where our threshold for diagnosis is not necessarily clear all the time. And we know normal pressure is very low, goes up a little bit with exertion. In the 70s and 80s, we went with absolute pressures of 30 or 45. And nowadays, we go more with a pressure gradient theory. So whatever the difference between the intercompartmental pressure is from the diastolic blood pressure is the pressure gradient. So if we are at 120 over 80, McQueen would say that a compartment pressure of 50 or greater would be analogous to a compartment syndrome. But again, this is trying to apply a dichotomous yes-no answer to what is really a gradient of tissue pressures. There's various measurement techniques. Basically, the older ones are sort of horrendously complicated, and you had to run all over the hospital to find all the different tools you'd need to do a compartment pressure measurement. Now, are some better devices like a simple needle that you jab into the patient's leg or arm and measure it off that. But again, the ultimate variable is defining what that pressure is and where that gradient sits along the line. In terms of tissue survival, there obviously is some benefit to getting on this early because the sooner we act, the more likely we are to have reversible changes that will probably get better over time, both in terms of muscle injury and in terms of nerve injury. McQueen looked at the value of pressure monitoring in tibial fractures, trying to again define what the best pressure threshold was for fasciotomy. So at 116 tibial fractures, decent numbers, using that 30 millimeter gradient from the diastolic gave a rate of compartment syndrome of about 2.6%, which is analogous to what we get most of the time in the literature. We're somewhere between 10% at the very upper diagnostic limit to about 2% at the lower threshold. So depending on how quick you are to pull the trigger on what is and what is not a compartment syndrome, you can expect that you're going to have around 1 in 25 or so patients with compartment syndrome. I don't know how many tibial fractures you guys do a year. For us, it's in London, it's around 125, 150 tibial nails a year. So that would typically be expected to result in somewhere between 6 and 10 compartment syndromes a year. Hello? A question from you. If we went with other thresholds, instead of that 30 millimeter gradient, if we went with a 30 millimeter absolute threshold, you get a fasciotomy rate of over 40%, which is clearly unacceptable. Even a slightly higher threshold gives you a 20% fasciotomy rate, both of which are unacceptable. So really, where we draw that line between normal and pathologic defines our instance of surgery and the risk to the patient based on pressure monitoring. Pressure monitoring does work, looking at patients who developed compartment syndrome. Those who were monitored and had earlier surgery, which is the bottom line that we're trying to achieve, obviously had much fewer sequelae. And again, McQueen's paper, 13 monitored patients had surgery at 16 hours with no contractures and amputations. 12 unmonitored patients took 32 hours to get to surgery, and of those, most had weakness and contractures. So fairly good evidence that getting on the patients early with surgery will definitely preserve muscle and preserve tissue. On the other hand, we're back to the same problem of determining a threshold. Patients with elevated intramuscular pressures after tibial fracture, looking at a whole group of patients routinely monitored, did not have a greater instance of complications than those with lower pressures. So how we interpret those pressures is still up for judgment. Routinely, patients with tibial fractures, if you monitor everyone, routinely you'll be over 40, over 50 in terms of the intercompartmental pressure. So that our role of interpreting exactly what a pathologic compartment pressure is still up for grabs. More important than the absolute number are things like the trends. Is the pressure increasing or decreasing? What is the time from injury to the actual diagnosis? Where are we at in terms of the course of the patient's management? Because almost everybody will at some point in their care have an elevated tissue compartment pressure that could be considered pathologic and lead to fasciotomy. So although compartment pressure monitoring is a valuable tool, we have to take it with a grain of salt and interpret it. Further diagnostic tools are certainly showing a lot of promise, like NIRS, intramuscular pH monitoring, which seems to be a very promising one, determining when the muscle moves from an aerobic to an anaerobic environment has a lot of value, and measuring the hardness of the tissue. There are lots of other tools. Again, the same problems evolved, though. Are we dealing with in terms of dealing with a biologic phenomenon that has a gradient of pathology and trying to apply a dichotomous tool to it? So our diagnostic skills with compartment syndrome are not perfect. The summary of the whole diagnostic quagmire to me is that we still need to have a very high degree of suspicion. Disproportionate pain may not always be evident. Pressure testing does have value in equivocal cases, but needs to be considered in context. And I realize that Zane's on call tonight, and you can probably anticipate 3 or 4 consults for compartment syndrome based on this. So I apologize to you, but again, our bottom line is to not miss the diagnosis, and when it is present, to make the call early. Now moving on to treatments. Classically, treatment has been surgery and really little else, but there are adjunctive treatments that are becoming increasingly available for management of elevated intercompartmental pressure, and that's where most of our sort of research efforts have been directed. This is a typical operation for compartment syndrome, which is basically a stabilization of the fracture and then a fasciotomy being performed. And certainly this is a tissue-preserving, a limb-preserving operation. It's a good operation, but it's certainly not a great operation. I don't think anybody in the room would sort of be jumping at the chance to have this done to their leg, and you can imagine that the recovery time is going to be prolonged. So surgery, while it prevents further injury, is not always the best tolerated by patients. The principles are to do a fasciotomy and to stabilize the fracture for most of our orthopedic patients. In terms of when a fasciotomy is performed, really it should be done whenever there's unequivocal findings and unequivocal clinical findings. So if you have the diagnosis of compartment syndrome, a fasciotomy is done, and it's relatively simple. If you have a pressure within 30 millimeters of diastolic blood pressure, I think from a medical legal standpoint, Unless you have good evidence that the trend is moving towards decreasing, then that patient should be certainly considered for a fasciotomy. Or if you just have significant tissue injury at risk for compartment syndrome. We had a patient this week who had a massive crush injury, telephone pole. Unfortunately, fell on him after a car accident. Came in with a leg and arm crush. And really, there's no question that that patient's limb is at risk of developing a compartment syndrome. Due to other injuries in the ICU, he's not able to cooperate with his exam. So even though his pressures were low at the time of the diagnosis and at the time of his initial surgery, that's a patient who in my hands would receive a prophylactic fasciotomy because that tissue injury has put him at such significant risk for complications. In terms of the how, it's basically very simple surgery, extensile incisions to release all the compartments and preserve the neurologic structures at risk. Necrotic tissues are debrided and coverage needs to be done expediently. So in a typical form, this is a cadaver, so it's not tissue under pressure, but you can see the length of the incision. It's basically the length of the arm, including release of the lacertus fibrosus at the elbow, release of the carpal tunnel at the wrist, to ensure that all the tissues at risk are completely released. Similarly, in the lower leg, complete release involves typically 2 incisions, but it can be done through 1. And again, it's a release all the way from about 3 inches below the knee to about 2 inches above the ankle. So an extensive fasciotomy should be performed. There are unfortunately numerous cases in the literature of recurrent compartment syndrome secondary to incomplete fasciotomy, or myonecrosis secondary to incomplete fasciotomy. So certainly my practice is to tend toward a more complete fasciotomy being performed. Once the surgery is done for the fascial release, the next step is to think about coverage, and we try and think about that early so we don't run into problems like shown in these pictures with sort of festering wounds that have had fasciotomies performed and subsequently become big scar problems for the patient, big management problems, and prolonged dressing issues. This is difficult on the patient. Sometimes that's unavoidable, but in general, we think about early coverage right at the time of the initial surgery. And I think this is an instance where the VAC, or vacuum-assisted closure, has helped us out a ton. To the point that for myself in the lower leg, where most fasciotomies are performed, we do a dual incision fasciotomy in a temporary VAC, and basically move immediately to soft tissue coverage at 48 to 72 hours, and there's really no waiting. If the patient has other fractures that need to be stabilized, even so, we're going to try and get closure at that 48 to 72 hour mark. How does that work? Well, fasciotomy is muscle preserving but poorly tolerated, and greater than 90% of patients will complain of complications after fasciotomy. And those can be adhesive scars, poor cosmetic appearance, or really something akin to post-traumatic stress disorder that results from a fasciotomy. So although it's the surgery of choice for compartment syndrome and is unavoidable and should be done really without too much second thought when you have the diagnosis in your mind, it's far from perfect. And that's led to more interest in things like adjuvant treatments. So we're thinking of adjuvant treatments for compartment syndrome. Really, you have to go back to the pathophysiology and say, what is in fact causing the muscle to die? In our lab, we focused on things like compartment syndrome leading to a low flow ischemic state as the cause of muscle injury. But over time, it's become more apparent that not only is inflammation present as a corollary to the compartment syndrome, but it's also in part causative of muscle injury. And we demonstrated that with one fairly decent experiment in which we rendered animals neutropenic. So we blocked the inflammatory pathways, seeing what effect that would have on muscle injury. So does blocking inflammation prevent muscle injury? And in fact, it did. This is a graph showing the percentage of muscle cells injured. So about 20% of muscle cells injured would be a line across here. This is the duration of the compartment syndrome on the lower line there. And you can see that after about 90 minutes of compartment syndrome, we had about 25% cellular death in the normal group, compared to only about 10% cellular death in the neutropenic animal group. So it kind of suggests that although all our models and thinking about compartment syndrome has been that it's a perfusion problem, this has led us up a different avenue saying that in fact there's an inflammatory component to the cellular injury. And that's probably worth tackling from an adjuvant treatment standpoint, because we can do something about inflammation non-surgically, although we can only restore the perfusion typically surgically at this point in time. So interestingly as well, we get muscle death as soon as 15 minutes after the compartment syndrome is induced, which again goes back to our goal of early diagnosis and earlier procedures being performed. Adjuvant treatment has received a fair amount of attention in the orthopedic literature in the last 5 to 10 years. Options such as hyperbaric oxygen and vitamin C, as well as N-acetylcysteine, have been shown to work. Indomethacin has been shown to work, which is a pure anti-inflammatory effect. Tissue ultrafiltration to reduce the pressure without fasciotomy is of benefit. And even IV or oral steroids and hypothermia have been shown to have some benefit. And we've sort of taken some of this onto our clinical practice. Patients with presumed or suspected compartment syndrome or severe muscle injury will get vitamin C as part of their initial care. It's certainly no harm done. They will get their legs cooled with a fair amount of ice or cryo packs after injury prior to surgery. So we are doing some adjuvant treatments already. But we've tried to work on this from an animal research point of view, looking at things like cellular perfusion, inflammation, and tissue injury, as well as functional outcome more recently. So in terms of the perfusion, this is an animal model looking at perfusion. I have a video here. I'm just not 100% certain it's going to show. We're going to look at the perfused capillaries, non-perfused capillaries, and intermittently perfused capillaries on this slide. This is the kind of thing we would see in the lab. So the perfused capillaries would be the ones towards the bottom. The blood cells you can kind of see are just racing along. Not sure if that's clear enough. The bouncing you see in that video is the animal breathing. So that's just artifact. In the middle here, I don't know if you can see it well enough or not, but it's basically you're going to see some sludging of the blood as it goes through the vessel. So that's an intermittently perfused capillary. It'll kind of go on and off as the video progresses. And the non-perfused capillaries, here's an example of that over on this side. So it just kind of goes for a while and then it stops. Right there, it stops. So we get an issue of the perfusion kind of coming through and then stopping. We can use this as a tool to evaluate the efficacy of our drugs to treat and improve perfusion. Okay, and this is the kind of graph you might generate with that. We can look at the non-perfused, intermittently perfused in the hash marks non-perfused in black, intermittently in the hash marks, and continuously perfused capillaries. With increasing duration of compartment syndrome, as you'd expect, the perfusion basically worsens. So we can generate this, and we can manipulate the animal with drugs and see what benefits we can achieve in terms of the perfusion. The second issue is to actually look at the inflammation, and this is sort of a standard model for leukocyte activation. So as the leukocyte's coming along and it gets activated, it binds to the endothelial wall, and then it progressively is going to work its way out outside of the blood vessel into the tissues around to do its work. And we can measure this degree of inflammation as well by measuring the behavior of the white blood cells. Oops, that one didn't work too well. Okay, I'm having issues with this video, so you'll just have to take my word for it that we can look at the white blood cells rolling and sticking to the cellular wall. And again, as the time of compartment syndrome goes up, we can basically see that the number of activated white blood cells increases concomitantly. And then we can look at muscle injury as well, which is things like simple staining techniques, looking at injured cells as a ratio of all cells. More recently, we're trying to do this with functional measures, so I apologize if this offends anyone, but I'm going to show pictures of the animals walking across the screen here. This one's going to have no compartment syndrome. Races across there pretty good. The benefit of this is we don't have to sacrifice nearly as many animals, and we can still see their function. So as this one walks across, look at its right hind limb, and as it comes across, you can see how the limbs all hit the screen and cause the little green marks. Stride lengths are equal. We can look at how much the foot spreads as the animal walks across. And now an animal with compartment syndrome, you can see it's lumbering across, and it has a wide footprint there, which is one of our best measures for dysfunction of the lower limb. So we've got an animal that's had compartment syndrome to its right hind limb, and now as it tries to walk across, you can see a different footprint compared to the other one. It's also got a different stride length, and about 100 other measures you can look at. So at this point, we're progressing more to survival studies of the animals where we can really look at whether our adjuvant treatments can do anything. And we're also progressing from small to large animal models. So what we want to do is have adjuvant treatment directed against this pathophysiology compartment syndrome, dealing with the inflammation and the perfusion deficits. And really the most promising treatment so far is actually carbon monoxide, which is really a naturally occurring breakdown product of the heme molecule. Carbon monoxide has all kinds of the properties that we're really looking for to deal with a severe and acute combined inflammatory and perfusion defect, which is basically compartment syndrome. So it's anti-inflammatory, anti-apoptotic, and it shows vasodilatory properties. It's even been featured in non-medical magazines. This is from July 2012, an article on carbon monoxide, the silent healer. So it's been shown to show some promise in various realms of medicine. Inhaled carbon monoxide is used in lung disease and transplant literature in the preliminary stages. And in this case, carbon monoxide confers resistance to oxidation, TNF-alpha mediated apoptosis, and ischemic lung injury. The problem with it also reduces cytokines. The problem with carbon monoxide, obviously, is well, it's carbon monoxide, so it's kind of lethal. So now we're trying different techniques with the carbon monoxide, things like binding it to other molecules, and this is it's called CORM3. It's bound to a ruthenium, which is a metal element releasing molecule. And the benefit of this is we can sort of define the dose of carbon monoxide to the tissue. So it's got to be fast to work in compartment syndrome. It's got to be water soluble, so we can mix it up and give it in the right dose. And it's got to release carbon monoxide in a predictable way and with a predictable dose. So that's what we're kind of working with right now, is this CORM3. So looking at a sort of fairly recent experiment, this is a 2-hour compartment syndrome model, an inactivated CORM, which is called ICORM, and an activated carbon monoxide releasing molecule. So one of the carbon monoxide releasing molecules doesn't actually release it, and the other one does. So I'm going to show you 3 different graphs on that, okay? And this is the first. So in the left side bar is the sham animals. They did not get any kind of compartment syndrome or medicine. And you can see that their microvascular perfusion is pretty good. Most of the blood vessels are still continuously perfused. This is after 2 hours of compartment syndrome with the inactivated CORM molecule, and only about 25% of the blood vessels are continuously perfused. If we give the activated drug, we can get that up to about 60% of continuous perfusion, about 20% intermittent. So that's really the biggest difference compared to our controls that we've been able to generate with any adjuvant treatment so far. So it's kind of promising. Perfusion gets better. In terms of the white blood cell activation, again, the inactivated CORM is in the middle bar, the activated CORM is in the far bar, and the sham or no compartment syndrome is here. So our adherent leukocytes, which is the bad ones, right down to the control level with this carbon monoxide releasing molecule. TNF-alpha, which is sort of a surrogate for the degree of cytokine release at the site of the injury. Again, we've got the inactivated CORM is the black line coming up like this. The activated CORM is the red line. In both cases, we've given the CORM right at the time of the fasciotomy, so this is not a pre-treatment. This is giving it at the time we'd probably be able to intervene on someone surgically, and we've really reduced that activation of the inflammatory cascade. So this is kind of promising because now we have something that while fasciotomy is able to reduce ongoing damage from perfusion defects, we've got something to also tackle the inflammatory side of the damage cascade. So this carbon monoxide releasing molecule shows a lot of promise. In terms of where we're at with it, we're at the stage of large animal models right now. This is a larger animal model, so this is in pigs now. You can see the muscle cell death with the inactivated CORM is about 30% with our compartment syndrome model, down to about 8% if we gave it the CORM. So I'm hopeful that this is sort of almost at the stage of preclinical studies, and will hopefully move forward. I think for sure adjuvant treatment is going to play a role down the road. And when you compare, a medicine like this, obviously got to be safe, so the carbon monoxide needs to be totally worked out in terms of pharmacokinetics and that. But if you compare the use of adjuvant treatment with something like this, then I think patients would probably have a pretty easy decision to make. So just to sum things up with compartment syndrome, we spent some time on diagnosis and spent some time on therapy, both surgical and adjuvant treatments. And thank you very much for your attention, and thanks also for the AV work there. I know it's not so easy to get that right every time. So thanks a million.
Yes. So we'll have some questions. I don't know if we'll be able to do it from the remote sites, but I'll start if that's okay, Dave. Do you see this as analogous to the treatment of necrotizing fasciitis in some regards, in terms of how, when you and I were residents, it was very much a surgical disease, and it still can be, but now with some of the medical management of that, the big surgery has taken a step back, and now it's early medical management becomes mainstay?
Yeah, I think that's a good question. So this is basically a compartment syndrome is just another form, a different version of a low flow ischemic state, and there's lots of applications for dealing with low flow ischemia. It's interesting that our low flow ischemic states generate more of an inflammatory response than complete ischemia, at least in the lab studies. So this is directed at could be directed at any pathologic process in which inflammation is contributing to cellular injury. Necrotizing fasciitis is one. There's probably some applications in vascular surgery potentially, and really one of the most interesting newer applications is more of an anesthetic concern, which is complex regional pain syndrome. Interestingly, a lot of the complex regional pain syndrome literature now suggests that it's potentially a low-level compartment syndrome as the inciting event. So, if we had something that actually worked on CRPS, then that would be very promising, right? There's a lot of different diseases out there that probably have a low-flow ischemia as their underlying pathophysiology that we're kind of working on.
And you talked about some of the other medical management, and you did have some of the anti-inflammatories up there, and certainly indomethacin is one of the most powerful ones. Do you not use it clinically because of the, in the setting of fracture management and the risk of non-union, or are you in your fracture management in those patients that have a combined tibia fracture or some fracture associated with a compartment syndrome? Are you, because we're always asked from anesthesia more from the pain standpoint about some of the anti-inflammatories, but if in the setting of a concurrent compartment syndrome, are you or are you not using anti-inflammatories?
I think it depends on the patient. So what we've done is patients with isolated injuries, so non-ICU patients, healthy people, no abdominal GI issues. I'm fine with them having 24, 48 hours of anti-inflammatories around the time of their injury. I don't think that an early block in the fracture healing cascade is a major issue in terms of their ultimate union rate. So I will give anti-inflammatories for that. Where we hold off is the ICU patients where stress ulcers are potentially more of a risk, and in that case, continuous repeated anti-inflammatory doses. We do worry about causing some harm with that.
In compartments, do you do it? Does it change someone is in compartments?
So what we do is try and get on them early with all the adjuvant treatments. So and the goal, like our ultimate goal, would be you have a tibial fracture, you come in, you're at some risk of compartment syndrome, and you get some kind of adjuvant treatment right off the bat, right? Currently, they get the safe things, which are thought to be vitamin C and cooling, limb cooling. But if we can prove that other options are routinely safe, then we move on to more of that.
Yeah, Charlie, I don't know if there's a way, but I'll repeat your question. So the question is the model of compartment syndromes that being done in lab studies, and essentially how do those translate into real life? And you want to go to how you induce compartment syndrome?
Sure. Well, there's no such thing as a perfect model, obviously, and there's certainly probably about 15 different models that we've seen to induce compartment syndrome or something similar to it in animal research. What we do is in the rodents, where we have the benefit of it has two relatively well-defined compartments in the leg, an anterior one and a posterior one. We inject saline or plasma, depending on the particular study, into the posterior compartment, and we measure the pressure in the anterior compartment. So it's sort of a referred pressure phenomenon from the posterior to the anterior compartment. That's how we've created our model. In terms of the ability of it to generate compartment syndrome per se, all I can really say is it seems to work. We've gone as far as histologic dissections, MRI studies, and it seems to look the same on that as a routine compartment syndrome would in a human. So it seems like it works. But there's lots of unanswered questions. One of them is the timing issue. Does an hour in our model correlate with an hour in clinical compartment syndrome? Since we don't go as far as generating frank myonecrosis in them, it's probably still best to be thought of as a sort of an early compartment syndrome model. And I think that in real life, as things kind of progress, as the pressure gets worse, as the time gets worse, we're probably past the point where things like adjuvant treatments have much of a role. So this is really trying to target an early model of compartment syndrome, a patient who kind of comes in with a swollen leg and potentially some signs of pain, but not necessarily myonecrosis yet.
Just call over. Can you hear me over there? It's Gus Chen. I'm at VGH. I'm wondering if I can ask you a question about, you were talking about post-op pain management for these fractures. And I was wondering if you think it's necessary to avoid regional anesthesia techniques for post-op pain management because of the risk of masking compartment syndrome.
I think that probably was heard over at the remote sites, but regional blocks perioperatively and their issues in terms of masking and not being able to detect clinically compartment syndrome. What Dr. Sanders' thoughts are on that?
I think that it's all just a matter of, personally, I think it's a matter of having that index of suspicion. So if you do a procedure which is potentially going to generate a compartment syndrome under a regional anesthetic, then obviously you need to do more careful post-op monitoring and need to consider alternate diagnostic techniques other than just pain. But I wouldn't go so far as to say that I believe that regional anesthesia is contraindicated in patients at some risk of compartment syndrome, because there's just enough benefits to regional anesthesia in many instances. And really the rate of compartment syndrome for most of the procedures we do is low enough that I don't think we can absolutely say we shouldn't do regional anesthesia in those procedures. That's sort of my opinion. It's funny because people have different thresholds for how far they will go to ameliorate a compartment syndrome. Like one of the common questions is, do you use a tourniquet for your lower extremity surgery, thinking that that is obviously going to contribute to some degree of cellular stress, if not death, and maybe not a compartment syndrome, but certainly something leading towards that. Personally, I use a tourniquet for the majority of my lower extremity surgery, despite the fact that there's going to be some oxidative stress on the muscle. And the reason is because I think that our goal as surgeons is to do, first of all, good surgery, and then to deal with the complications. So personally, I think that although regional anesthesia probably makes things harder for us in terms of diagnosing compartment syndrome, probably the benefits outweigh the risk in a lot of situations.
So then we'll go with Steve. Steve, you want to? So the question from was the actual first responders, the emerge. What should we be doing to try and minimize compartment syndrome from the basics onto the adjuvant side of things?
It's a good question. I think that there's lots of things you can do, and most of them are actually, fortunately, quite effective. I think that early stabilization, not necessarily surgery, but early stabilization is important. We all have the problem, at least we do here. I'm sure you're in the same boat, where someone comes into a crowded emerge and waits around for a few hours to get something looked at, and certainly that contributes to swelling. So there is an issue of triaging patients with more severe injuries more quickly. Early splinting is obviously important, and reduction if possible. Certainly reduces anything that will reduce the inflow issue, or anything that will cause less bleeding in the tissues is going to be ultimately advantageous. In terms of cooling and elevation, we want the limb just slightly elevated relative to the position of the heart, so we don't cause issues with either inflow or outflow. We want to ensure that we've facilitated drainage of the limb without reducing perfusion. And there is some emerging literature that you don't want to overdo it because you'll reduce the inflow if you get the arm up too high. On the other hand, you want to make sure that you're facilitating drainage. So just slightly above heart level is really ideal. And then in terms of the hypothermia, we just do a 20 minutes on, 20 minutes off ice pack strategy to most of our tibial fracture patients, and a lot of the kids as well who come in with forearm fractures.
All right, Chris. The question was about myonecrosis or muscle death and the potential for regenerative recovery, I guess.
Yeah, that's a good question. I think, in our muscle is one of those tissues that fortunately has a great regenerative capacity for most cases. So we're dealing with sort of a low-level muscle death that honestly in the animal models we use has a very high regenerative capacity. So you do, it sort of begs the question that is this really necessary to go this far to prevent muscle necrosis if it's going to regenerate anyway? And my feeling is that not only is preventing muscle death important from a strength and contracture standpoint, but probably from a pain standpoint as well. That if we can minimize the insult to the tissues at the time, then we're probably going to have much less pain, much less sort of early dysfunction as part of our fracture care. And that's obviously one of the goals. I mean, we move more and more to immediate weight bearing after fracture fixation, to sort of immediate functional recovery, getting patients back to activity and work as fast as possible. And I think maybe this low-level compartment syndrome issue may play as much of a role to that strategy, to reducing disability early on, as it does to actually long-term outcomes.
Dr. Nelson?
No.
So the question was, are we using steroids in any of the ICU patients or anybody at risk? And David?
No, it's a definite no on that one. Yeah, we don't use any sort of. What we really like to do is have a treatment that was directed really site specifically, right? As opposed to the general effect of steroids, which in the spine literature kind of went through a wave of popularity, and now we don't use steroids at all for spinal cord injuries, at least in London. And I think this is sort of the same situation where if you really looked at it closely, we'd sort of back off from steroid use to sick patients in the ICU to prevent these kind of complications. So we're looking for something that's a lot more injury specific, tissue specific than the broad blast of a steroid.
Yeah, Jason? So the question is in terms of fasciotomies, timing of it in terms of an established diagnosis of compartment syndrome, and when would you not do a fasciotomy, and because of the risks of a late fasciotomy are sort of well out there in the literature?
Yeah, it's a good question. I don't have a great answer for it. From a temporal standpoint, if it's within the first 48 hours of injury, then I'll always make an effort to release it. Similarly, if the patient has any degree of muscle function, any degree of muscle contraction, then I think there's something there that probably can be salvaged. The ones that we've held off on are basically fitting two criteria, that is greater than 48 hours from the injury or greater than 48 hours of an established compartment syndrome with complete paralysis of the affected compartment. If those two situations are present, then I'll hold off on the compartment syndrome for the risk you mentioned, which is basically causing an infection in a currently intact compartment. The other situation there that is an issue is if you have someone who's developing renal issues secondary to ongoing myonecrosis, and whether in that case a more thorough debridement of the compartment is required. So that would be a fasciotomy and debridement procedure as opposed to isolated fasciotomy if you're into the renal situation. Okay. Yeah. So the question was, where do you measure compartment pressure? And I think the best answer is actually lots of different places. You want to get as many sample sites as you possibly can. There's literature that says you have to measure the compartment pressure within about 5 centimeters of the fracture in a fracture situation, and that's where you'll get the highest readings, and that makes sense. But typically, we're going to measure at least 3 stabs in a compartment that's at risk. So 3 different sites along the muscle. And if you're doing a continuous monitoring situation, then whichever one is the highest is the one we sort of put the monitor in and repeat at.
Okay, if there's no more questions, we'll wrap it up. Thank you very much. Thanks, Dave.
Thanks.